Now, from the News Channel 5 network, this is Medical Mondays.
Good evening, everyone. Welcome to Medical Monday. I'm Carrie Sharp. Tonight's topic I know is something that all of us have dealt with, and maybe even once a week. Headaches, specifically migraines. That's what we're talking about tonight. If you have questions about headaches that you're dealing with or a family member is dealing with, tonight is the night to call. Again, it's your chance to get some free medical advice. Nothing beats that in today's world. So go ahead and give us a call. The number is on the screen. 615-737+ is the number to call. And as always, we are going to get to as many calls as we can tonight because I know that's important to you. Dr. Jan Brandis is our neurologist who is in with us tonight. Thank you for being here.
Thank you for having me, Carrie.
You see patients in your private practice. Tell folks where that is.
My office is in the 300 20th Avenue building, so I've been there for a long time.
You were saying you've been doing this for 25 years here in town.
This is my 25th year of neurology practice.
Congratulations.
So it's gone by fast.
What made you want to study neurology specifically?
I had a really remarkable neuroanatomy teacher at Vanderbilt when I went a long time ago, Dr. Jeanette Norden. And she's really a neurophysiologist, and she made neuroanatomy so alive. She was one of those people who can teach you everything about the central and peripheral nervous systems and connect it to how it works, the physiology of it, and then she would bring in patients and their families to talk about neurologic disease. And I was totally captivated, and that was it.
And now it's your life's work.
And now it's my life's work.
Over the next hour, and I think everybody at home wants to know, and we want to learn more about headaches. Why do we get headaches? Where does it start?
Well, there are many. I guess you could say it starts if you have a brain. So probably under any set of perfect circumstances, you can have a headache. But there are many headaches that are completely benign, that happen very infrequently. Probably one that almost everyone's had is an ice cream headache.
Yes.
So the ice cream headache where you get that dollop of cold.
The brain freeze.
The brain freeze. So that's probably the headache that every little person experiences, and grown-ups too. So that would be a very common benign headache. Another one would be cough headache. So if you have the flu or you have an upper respiratory infection and you cough a great deal, you can trigger. It's a completely benign headache. There's nothing wrong inside the brain or inside the skull, but a tremendous amount of coughing can produce headache. And it's because you increase the pressure in your chest when you cough, and that gets transmitted to brain. And again, you have a skull, so you have a closed
There's
object.
nowhere for that pressure to go.
That's exactly right. Another of the so-called benign headaches is one that's really sort of not always people, it's always something that patients will say sort of sheepishly they want to talk about. It's the headache known as coital cephalalgia. It's headache that occurs as one nears orgasm.
Really?
And it can occur in men or women, and it's a pretty breathtaking headache. It's excruciating. So just as orgasm is neared, there's a very tremendous head pain, and it usually is fairly short-lived, though it can last longer. And we do image patients. We get imaging studies of the brains in people who have that particular pattern, but in most studies, about only 1% of patients who have that pattern have anything wrong, and it may come and go just as
everything else does.
So there are a lot of headaches that are really very benign, meaning they don't lead to something else, and those are the ones that many people experience just through
it's just part
lifetime.
Of life. Okay, well, let's talk about the ones that are not benign.
Well, probably the most common headache that occurs worldwide is tension-type headache. It used to be called tension headache because it traditionally is a headache that goes around as a band around the head and is usually in the front, temples often in the back.
Yeah, so you think you're tense and you're furrowing your brow and you're tightening your shoulders, that kind of headache, right?
That's exactly right. So that often gets labeled. They used to call it tension headache, stress headache. It goes by a lot of different names. The really approved name for that is tension-type headache.
Okay.
And it's always both sides of the head. Rarely is it extremely severe, but it can be aggravating because it's mild to moderate, can go on for a long period of time, days to weeks. Usually there's not light and sound associated unpleasantness with it. And it's the kind of headache where after you've been under the studio lights for a long time, if you have that, you might go home, put on your tennis shoes, run for a while, and then that headache would usually get better. So it's one of the rare forms of what is called primary headache, which gets better with physical activity.
Interesting.
So that's the most common one worldwide, and it's considered a primary headache, meaning that the headache is the problem itself. It's not a sign of something underneath. The primary headache that takes most people to physicians or to nurse practitioners or PAs, that takes them into emergency rooms, is usually migraine. So I've told the medical students I work with, remember, I'll be coming back to haunt you if you ever label a headache that you see in the emergency department as being migraine, because it would be very rare if you label it as a tension type headache.
Oh, I gotcha.
Because tension type headache does not appear in emergency settings because it's traditionally not severe enough. So migraine is the headache that is the most common that appears in medical settings.
For people who have not had a migraine, I've only had one in my life, and I'm thankful to only have had one. It was after I got my wisdom teeth pulled. Whew, Lordy. But for people who have not had one, explain what the symptoms are. They are severe.
They can be very severe, and of course people can have milder ones, but let's take the example that most people know. So migraine without aura, which means just the headache component, when it starts, location doesn't help you. So for many people, the headache will begin as a mild pain. It can move to moderate pain, and then it can get very severe. So it can be in any location. 60% of the time, a migraine attack is on one side of the head. So about 60% of the time, it's one-sided. That means, of course, that 40% of the time it's both, so you can't always rely on that. But one-sided in many cases, moderate to severe. It's throbbing or pulsing, so people will sometimes say they feel it like their heartbeat.
Right.
And then last but not least, and this is probably the critical differentiating feature between migraine and tension type headache, is that the headache is made worse with routine activity. So for you, that would be being here doing what you're doing with the light and sound. But for others, it might be bending over to tie your shoe. It might be walking up a flight of steps. It might be picking something, reaching down to plug a computer cord in. Those are routine activities, not exertion, just routine activities make that headache worse. If people have two of those four, so one-sided, moderate to severe, throbbing or pulsing, and worse with routine activity, two of those meet criteria for the headache of migraine. And then the associated features for that are light and sound sensitivity, the so-called photophobia, phonophobia, the fear of or the unpleasant perception of sound, nausea and or vomiting. So they only have to have really one of that set. So it's easy to see why, if you happen to be someone who has headache on both sides in the front, and it's, let's say, moderate to severe, both sides, worse when you bend over, triggered by a change in the barometric pressure, and maybe you just have some light and sound sensitivity, you don't vomit. What would you suspect that headache might be labeled as?
I would say migraine. But
well, that's because you're knowledgeable. Many people,
I've been listening.
Many people would say that's a sinus headache.
Really?
So
because the bending forward, the pressure.
Forward in the triggered by the barometric pressure. So migraine is not, location does not help us in migraine. So migraine can be here, it can be the back of the head, often labeled again as tension or stress. Sometimes it gets those different labels based on location, but it's really based on the quality of the headache and the associated features.
Gotcha. See, we're all learning something today. Again, if this is striking a chord with you, if you have a question, you need to go ahead and give us a call. 615-737-PLUS. We do have some phone lines open, so give us a call. We'll line those up during the break, and when we come back, we'll get right to them. Stay with us. More Medical Monday next.
This week on Fishin' Affliction TV.
Come on, big dog. Tell me, how's that feel to you?
Join Team Fishin' Affliction for part 2 of Fishin' the Big O as they're fishing legendary Lake Okeechobee.
Come on. Big dog, you made the call, man.
That
man.
Your Fishin' Affliction TV weekend begins Saturdays right here on News Channel 5 Plus, your home for
Fishin' Affliction time for those who've got it bad.
Big news from Beverly Hills. Celebrity plastic surgeon Dr. Andrew Orton has discovered an anti-aging breakthrough called Fill and Freeze. And he's giving away 1 million bottles free.
Wow, I'm young again. I don't feel like an old lady. Lines are gone.
It definitely took 10 years off. If I went to a dermatologist here in the city, I would pay $400 for this.
I spent nearly 30 years looking for an effective, instant breakthrough to reduce the appearance of wrinkles, and I finally found it with Derm Exclusives Fill and Freeze.
This instant wrinkle-removing miracle sells for $60, but get yours now for only $39.95, and will include a second tube free. Dr. Orton will even include these 3 anti-aging bonus treatments, a $200 value free. But you must call to order. Call 1-800-616-7629. That's 1-800-616-7629. Order now.
She stands in the face of evil and will not lose hope or faith. America, the land of freedom, is still the home of the brave. So raise the banner. America always stand. History will write the story. America will always stand.
Person.
Welcome back to Medical Monday. We're here with Dr. Jan Brandis talking about headaches and migraines today, and I knew this would get you calling. We have lots of callers on the line. We're going to get right to you. We have Jennifer on the line. Jennifer, go ahead with your question for Dr. Brandis.
Hi, my question is, I'm on hemodialysis 3 days a week, and when I leave dialysis, it's a progressing headache, and it gets pretty bad. It's in the back of my neck pretty strongly, behind my eyes, sometimes on one side, maybe.
Are you wondering what you can do about this, or if there's any way to prevent it?
Yes, ma'am.
Okay, let's see what Dr. Brandis has to say.
Well, have you had headaches before? Is this a new pattern for you?
I had some sinus headaches in the past, but nothing like this, and this is pretty regular.
Okay. And do you mind if I ask how old you are?
I am 50 years old.
Okay. So, you know, so we will assume by 60 hormones are stable. Do you happen to be on hormone replacement, or are you off, not on any hormones?
No, I'm on blood pressure medication. Blood pressure is an issue with kidneys.
Okay, yes, but not on any estrogen or anything like that at 60?
No.
No, okay. So that means that the hormonal piece of this is really stable. And there are a number of things that can contribute to this. Migraine doesn't really start after age 60, or after age 50 to be specific. But sometimes those earlier sinus headaches may really, if you examine them, they may have been migraine. But the important thing now is that since you're undergoing hemodialysis on a regular basis, is to really look at, is there any metabolic shift that could be making you vulnerable to this headache? If it's a new pattern of headache, it may be important to see what your blood pressure is as you're coming off dialysis. So again, sometimes those blood pressure shifts can make a difference. They can trigger headache, especially since you've described this pattern and then it worsens. Sometimes there are changes in electrolytes, as you well know. You've been on dialysis for a while, that can make a change. So I think for you, what we would call this is really a secondary headache that's probably related somehow to the flow shifts or metabolic changes or blood pressure shifts with the dialysis. And it would be important really to talk to your nephrologist about ways or strategies, if you can figure out what the underlying cause is, but how you might modify that. Now, if it turns out, let's say, that there's no structural lesion, there's nothing there that's not supposed to be there, and your blood pressure is really doing all right, or the blood pressure meds can be adjusted to do that. Maybe there's a change made in terms of how much volume is pulled at hemodialysis. At that point, then what you could consider doing, or your nephrologist could consider doing for you, would be to take something before the end of hemodialysis. That's sometimes referred to as preemptive therapy. So you put something on board, an acute preemptive therapy that would try to keep that headache from developing, because sometimes headache in that setting is related to inflammatory release. So a sterile, it's not infection, it's a sterile inflammatory release, and sometimes using something in that setting can really be helpful. So that your situation is a bit more complex because you've got other things, but I certainly think that because it's when you're having to have dialysis, you certainly don't want anything that adds to discomfort during that, and certainly not after you get home and then having to deal with headache in the day when you're off dialysis. So I think that's a place where really talking to the nephrologist and trying to investigate the cause.
Jennifer, good luck with that. Thank you for your call today. Has a lot on her plate there. Let's go to Melanie. Melanie, what's your question tonight?
Yes, good evening.
Good evening.
I was diagnosed with frequent sinus headaches. I have allergy and asthma, and would have reoccurring sinus headaches for many years now. A couple of years ago, they got to the point where I did have auras. Sinus headaches would, or assume a sinus headache would only be on one side of my face, to where I had just excruciating pain bother me, and also nauseated. Went to a neurologist, and he prescribed me Furosec. However, there's times where I'm not really sure if it is truly a sinus headache or if it is truly a migraine, because they are so similar. I feel the face pressure with the sinus headache and allergies and hay fever, but then when I take a sinus medication, it doesn't help. But then I don't want to take my Furosec because it's a narcotic, so I can't necessarily take that throughout the day, and it depends on if I take the Furosec. Once that headache's gotten so far gone, it doesn't help either. So that's why I'm kind of confused, as I know you spoke earlier about the differences, or where you can easily confuse. Like yesterday, I had a headache that was the back of my neck, facial headache, the pressure and everything. But now I have coughing reoccurring now, so I'm assuming it's a sinus headache and not a migraine.
Any tips for Melanie how to distinguish the two so she can get ahead of if it is a migraine?
Well, it can be very tricky, honestly. I would say that in general, one of the mantras in headache medicine is that if you have recurring headache that is fairly similar, that continues to happen, and it interferes with your activities, that's usually migraine. I think in medicine we absolutely never say never. But I think the thing I would say is don't let location fool you, because location really does not help with sinus versus migraine. And in general, sinus headache is headache that includes fever, pus, so you've got really a pocket of infected material, and an imaging study that shows that. So really, sinus headache is a very specific constellation of circumstances. Migraine certainly can be triggered by nasal congestion, or nasal congestion can be part of migraine. That's sometimes referred to as an autonomic feature, and that's also seen in cluster headache, but it's very common in sinus headache, it's very common in migraine. So you can't necessarily use nasal congestion as a marker solely for sinus headache. So you can't depend on location, you can't necessarily depend on sinus congestion, you really can't depend on the severity in general, because sinus headache, if you have fever and pus, can be very high, and migraine we know can be very intense. So what you really have to look at are patterns. So if you have recurring sinus headache, I think it's important to look at that. And I suspect that if your neurologist gave you Fiorinol or Fioricet, they were perhaps thinking about something besides sinus headache, whether that was discussed. And so they may have been waiting until you come back to think about that pattern. Keeping a diary of the headache will be really helpful to you, but when you start having aura, visual aura, the most common pattern in migraine, where people have little zigzags, little sparkles, sometimes they'll have a black spot or a white spot that will enlarge and make the vision go away. Again, if you close one eye, you can see the sparkles. If you close both, close the opposite eye, you can see the sparkles, because the sparkles or the zigzags are really coming from the back of brain. So they're not really coming from the eye. It's a neurologic, it's an event in migraine. So if you're having aura, that is most assuredly not sinus headache. So migraine aura is exactly that. It's the aura of migraine. You can have migraine headache without having aura. You can have aura without having headache, and you can rarely have aura with cluster. But the 95% of migraine aura comes with migraine. So if you're having aura, that's your first clue that there's probably an underlying pattern of migraine. And you know, I think the other thing is that if you take something and it makes the headache go away, lasts maybe a couple of days, and then it's back in another week, that's another sign. That's another sign of migraine. So migraine in adults lasts 4 to 72 hours. So if that's the pattern, and a lot of times you'll see people get placed on an antibiotic, and they'll have a sinus pack, a dose pack, a Medrol dose pack, and they're better in 3 days, and they think, well, gosh, I'm better. And then the next month they have another one. That's a clear, I would say, signal that you may be dealing with migraine. So recurring attacks that are very similar are very often migraine. And the reason that's important, and it's not that allergies shouldn't be treated or that certainly sinus infections shouldn't be treated, but the migraine really needs to be treated too. And you can be treated usually with something that's more migraine specific than Fiorinol. The problem with Fiorinol, Fioricet is they contain butalbital, and that's a medication. It is a barbiturate, and that can produce rebound headache or move frequent headache into even more frequent headache. Now we sometimes refer to that as medication overuse headache.
Yeah, and nobody wants to do that. I mean, we all know that's not safe, especially in the long term. So it sounds like Melanie may need to go back to her neurologist.
Yes, and I think that one of the things you can really do in that setting is to keep a diary and mark where the headache started, how high did the severity get, did you have nausea with it, did you have aura with it, because those are the kinds of things that will let someone decide. And again, you can have more than one pattern, but it's certainly, I think we would have to say, we can't diagnose over the telephone, but I think we'd have to say that many of the features, you're very articulate about describing those, many of those things really do make me think that you may be having underlying migraine.
Melanie, good luck with that. I hope that's been some help. I'm sure it has. Let's jump to Pam on the line, waiting ever so patiently. Pam, good evening to you.
Good evening.
Hi, go ahead with your question.
Okay, well, I have a kind of a little statement. I've suffered from migraine since I was 10 years old. I'm 55 now. Under another neurologist, I've had the Botox, nerve blocks. I've been, chiropractors. One thing the doctor did tell me that I have occipital neuralgia in addition to migraines. So, you've been a neurologist, knows that's two separate pains. I've had sinus surgeries for my sinuses. I take allergy shots. Weather kills me beyond belief. My migraines are getting worse now than what they've ever been. I'm under the care of a doctor, and I can have a headache 5 days a week. And I'm just really frustrated and tired.
I can certainly understand that. What would be your advice for Pam?
Well, I think, childhood is a time when many adults who go on to have quite severe and frequent migraine, it's a time when it often begins. So certainly, I would say, unfortunately, Pam, a certain percentage of adults really don't get better after age 50. By that I mean they don't naturally get better after age 50. So it's really important to have somebody working with you that's trying various interventions. And it sounds like you've really done that. You've had occipital blocks, You've had Botox, which is offered for chronic migraine. You've had chiropractic, so you've had chiropractic manipulation. So you've had a lot of different things. But I would just say I'm pretty much a believer in the folks that practice with me. We're pretty much a believer in never say never. There are some really exciting new preventive medications that are coming out. We think the first one, which is a calcitonin gene-related peptide antibody, it's a human monoclonal antibody, will probably come out next year. That's already been submitted to the FDA. We've participated in those clinical trials. So there really are some exciting things that are coming out. But in the meantime, I think that for any chronic condition, and once you pass 15 days a month, we really refer to that as chronic migraine. As you know, it sounds like you've had a lot of experience with this. But doing things, and you probably are doing all these things, but I think they merit sort of repeating, making sure you're really well hydrated, that you're getting plenty of water, that you're really minimizing caffeine and limiting it to a small amount in the morning if you are a caffeine responder, and not really drinking it past about 9 o'clock and having a small amount then. One of the things that we recommend is the South Beach diet, because that particular diet is one that's very helpful for migraineurs, because it has it really includes adequate protein, it includes fewer carbs, so it helps people with their energy level, and it really helps supply a steadier supply of glucose to brain without the zigzags that, 2 donuts in the morning and then the crash and then up and down. And again, it takes work, but it really can make a difference in terms of headache. Many people don't eat, they skip meals. That can aggravate migraine. And then certainly sleep is very important. Going to bed at the same time, getting up at the same time, really trying to have very restful sleep. So, and then regular exercise. And when you have headache like yours, it's hard to really be able to do exertional, because we talked about that's one of the criterion, is that physical exercise, even routine, can make it worse. But just walking, just trying to do something that gets you moving a bit. The other piece is for you at 55 is to make sure that your hormonal status is really stable. Some women continue to have menstrual cycles until they're in their mid to late 50s. Some women are on hormone replacement and may never have noticed that it made them better or worse. So really assessing the hormonal component with your gynecologist or with your internist or primary care provider, those kinds of things can make a difference. So really all those things do is sort of put in place the kind of threshold that keeps migraine from being worse than it is. And then once that's done, I think it's really very important to look at different preventive medications. And it sounds like you've been on a lot of them, but I will tell you, I mean, we're just pretty much a never give up approach. And a lot of times it takes a certain dose, so the dose has to be high enough. It often takes combinations, because many people really need, for headache as severe as yours, when you've had it now for, what, 45 years,
yeah.
You really have to do all the behavioral things. It's not fair, I want to say that, it's not fair, but you have to do a lot of behavioral things. You really have to also probably be on combination therapies, and then take something when the headache gets to a certain level. So there are a lot of different strategies, and it sounds like you've really had a lot of them, but I would say that it's working on those basics that can help your threshold be higher so you're not as easily triggered, and then continuing to work on combinations of medications. There are a few centers that are available across the country for inpatient management. They're different places, but it's really important to be working with somebody that feels very comfortable working with complicated headache.
And it may take some trial and error, it sounds like, to figure out that perfect combination for you.
Yes,
yeah.
Yes. I always think someday I'd love for us to have the little skin scraping where we then can say, this is where your defect is in migraine, or this is where your abnormality is, and here's the drug that works perfectly
and it's going to be perfect.
I think we'll get there someday. I don't know if we'll get there in the next 2 or 3 years, but we're going to get better.
On that note, we're going to take a quick break. More of your calls and questions when we come back here on Medical Monday. Stay with us.
This is a Storm 5 HD weather update. Sign up for Weather Call at newschannel5.com.
Rain is on its way out of the mid-state, and comfortable weather is actually on the way in. There's a little irony here. Technically, today, Monday, is the last full day of spring. Summer officially starts late Tuesday night, just before midnight, And kind of ironically, the humidity will actually be fairly low, under control for this time of year, and we're looking at seasonable temperatures. So what a departure from what the heat and humidity we had last week. Speaking of temperatures, this is what it looks like across the southeast and, of course, current conditions right here in Nashville. Overnight tonight, we are going to drop down to around 63 degrees for that overnight low. Patchy fog possible under mostly clear skies and light winds. That fog mainly due to all of the moisture that's still on the ground from Sunday's rain. Tuesday will be really nice, sunshine, blue skies, 87 degrees for your top temperature, a bit of a gentle breeze. Will warm a touch into Wednesday before rain and cooler temperatures slide in for the weekend.
Your day moves by pretty fast. Chances are you missed something.
Before you call it a night, let us catch you up on everything you missed
and get you ready for a busy tomorrow.
Watch News Channel 5 at 10. Then rest easy
knowing the last word on everything that happened today.
And feeling ready for whatever happens tomorrow.
Get the last word on everything new.
Watch News Channel 5 at 10.
Our community is rising. And in the push and pull of progress, reliable information keeps you connected, safe, alert. Trust is everything. The News Channel 5 network runs toward the future, eager to tell it all, hold the powerful accountable, and keep a watchful eye over everything you hold dear. Thank you for trusting the News Channel 5 network to be your news and information leader.
Welcome back to Medical Monday. I'm here with Dr. Jan Brandis, a neurologist here in town, and you were telling me neurologists are harder and harder to come by when it comes to that headache specialty. This isn't something that people are seeking out much anymore, it sounds like.
No, interestingly, we have, I think there are now 21 headache fellowships across the country, and last year, the last number I heard was that 7 filled.
Just
so
7.
Most of the headache care in the United States is really provided in primary care settings. So it's always fun to be able to work with medical students and to work with primary care residents to really talk about this, because they are the ones who will see the vast majority of headaches, and pediatricians in particular, because if you can identify the migraine patient early, and we believe treat acutely and then watch their hormonal influences, and then make sure they are treating with acute medicine that stops the attack quickly, you hope that you can prevent that escalation that I think Pam was talking about, where you go from childhood headache into chronic daily, or at least over 15. And migraine's actually more common in boys than in girls until girls begin having their menstrual cycles.
Because of hormones. We love those hormones. I want to ask you about that. I told you I have a 4-year-old and a 2-year-old, and they've never complained about headaches. I wonder if it's because they don't know what it is or don't know how to verbalize it. But when do children really start having headaches? Do we know generally?
Well, some children have what we would call childhood equivalents of migraine, even as young as your 2 little ones. So there is a paroxysmal or sudden vestibular change, so they may hold on to the crib. That's how it was first described in a sibling pair. They would hold on to the crib. You could see their little eyes going back and forth. They would hold on because they were having this episode of dizziness. They would vomit and, of course, cry, and then it would last for a few minutes, and then they would lie down, sleep. When they woke up, they'd be fine. So that's, you know, they're too young to really say, I have a headache, but those are viewed as childhood equivalents of migraine. So it's a benign paroxysmal pattern of dizziness that is a vestibular pattern. That's really how children present. Some children have abdominal migraine, where again they don't complain of headache, but they have cyclic patterns of nausea and vomiting. And sometimes they get huge gastrointestinal workups, and then they run across a GI specialist that goes,
wait a second,
maybe this is migraine.
Really?
And again, that's so it's really, pediatricians are really, and family practitioners who take care of children, they're often the first line for migraine. So it can start in, you know, virtually from infancy to toddler years. But many children will, I'd say of my adult patients, like Pam, I would say of the ones who have chronic migraine more than 15 days a month, I would say more than half of them began having headache in childhood.
And that's terrible, because sometimes the parents are like, come on, you're fine, just let's go. When do you know it's more than that. You need to take it seriously.
Oh, I think mother's intuition probably plays a really strong role in that. It's really interesting to me, though. I'd say that most of the time, mothers are more likely to be, or fathers are more likely to be dismissive if they have migraine, because they're often afraid that their child is mimicking them. They've heard them or seen them, when in reality, that child's got about, if they've got one parent with migraine, they have a 50% chance of getting it. If they have two, they have a 75% chance.
Wow.
So they really need to be paying close attention. But I would say that in general, if a child can, you make sure they're hydrated, if they can lie down and take a little nap and the headache goes away, that shuts down firing in the dorsal raphe nucleus, so that's really helpful during migraine. That's a very common way to treat it, because pediatric migraine is typically much shorter than in adults. So if they do that, that's, I think, a great way to do it. But when you notice they don't want to go outside to play, they don't want to go to school, they are missing athletic activities, or they're just missing things that are to them are fun,
sure,
I think that's a time to talk about it with their pediatrician or their family practitioner.
I want to let everyone at home know our lines are open right now, so if you have a question, go ahead and give us a call. We can get you right in. 615-737-PLUS is the number if you have a question about headaches, about migraines. Now is the time to call. You mentioned that boys tend to have more headaches until that hormonal stage, when girls take over a bit. Let's talk about the hormonal effect on headaches and migraines from, when you start your menstrual cycle to premenopause.
Well, once girls start having their menstrual cycles, their numbers go higher than boys in terms of migraine, and they stay up for the rest of their lives, although the numbers do come down after menopause, after natural menopause, in about 45% of women. So when women have ovulation and the estrogen bump goes up then down, then the higher rise in estrogen and the bigger fall in estrogen triggering the menstrual cycle, that fluctuation in estrogen is felt to change the excitability of the neuronal membrane, and that, if you have one of the genes for migraine, can give you that susceptibility to attack. So many women have ovulatory migraine and they have menstrual migraine, and that can occur at any point. So some women have it 2 days before the first day of their menstrual flow. Other women have it the day of the menstrual flow. Some women have it after the estrogen's going back up. So it may be different with different periods. That's where a diary is so helpful.
And I'd imagine then, if you can kind of track, okay, I usually get it 2 days before my period or 2 days before I ovulate, then with preventative medicines you can say, okay, I need to be taking this now. Is that fair?
That's exactly right. That's not only fair, but that's exactly the way to do it. And if you can identify it, say, in an adolescent who's just started that pattern, you may be able to use a single dose that will stop it if it's a one-day attack. The other thing you can do is to use something called short-term menstrual migraine prevention, which is where you take a long-acting migraine-specific medication like a triptan, naratriptan, and frovatriptan are two that have been formally studied in clinical trials for this. And then you start it before that drop, so you try to keep it, and they may take it for 4 to 6 days just then to see if you can prevent that attack. So exactly what you're talking about. So it may be a single dose or maybe another one. So those are times when girls are vulnerable. And then about a third of young women who go on an oral contraceptive pill that contains estrogen get worse. So a third get better, a third have their migraine get worse, and about a third are pretty neutral in terms of headache. So it's important because to think about it and to be conscious of what's happening with your migraine. So sometimes people will notice they have bigger headaches. That may be the first time someone has migraine with aura. So that's a common thing to have it at that time. And if people are not being careful, what they may not realize is all of a sudden the headache's gradually getting worse and worse and worse. And Dr. Lee Kudrow, who's the father of Lisa on Friends, he was is a very well-known headache specialist, and he described back in the 1970s that starting someone on the pill could serve as a way to transform the headache from episodic headache to chronic headache. In other words, going from fewer than 15 days to more than 15 days. So it's an important thing to watch. And if girls can't be, or young women can't be on oral contraceptive pills, then they need contraception. They may go to something like the Mirena, the Skyla, so they're different. And then some women just don't do very well on the pill. Other women actually have their migraine improve. And sometimes if they're just left with a placebo week of menstruation, they can drop the placebo week and take it continuously.
Wow.
So there are lots of different strategies, but it's important to really think about, is it safe? If you smoke, and you have migraine with aura, you may not need to take the pill because it may increase your clotting risk. So again, if you have no history and you have your clotting enzymes are normal or your clotting factors are all normal, that may not be an issue for you. So it really takes, I think, a careful approach to it. And to make that determination. Pregnancy is another time. Pregnancy is a higher estrogen state. Many women get worse in the first trimester, better after that. Some women have no migraine through their entire pregnancy. If you have infrequent migraine or episodic migraine, you're much more likely to have none during pregnancy. Whereas if you're someone who has daily headache or you have chronic migraine, you're much more likely to have it not improve during the pregnancy.
And then the question is, what can you safely take?
What can you take?
Yeah,
that's right.
absolutely.
And that's always
tough.
trickier.
Sure. Let's jump back to the phone lines. Lily is on the line. Lily, good evening to you.
Hi.
Go ahead with your question.
I had a question about, I don't know, I missed some of it. I don't know if you said anything about hereditary. My son started having migraines when he was 4 years old. He has now passed away, and his son is having migraines also. So I'm just wondering, did he pass it on down to him?
You have about a 50% chance of passing one of the migraine genes down if you have a parent. So your little grandson has about a 50%.
He's 18 now.
Okay, well, that seems little to me. Okay, I'm not a pediatric neurologist, but so your young man has about a 50% chance of having gotten the gene from his dad.
Okay.
If his mother has it, he has about a 75% chance of having migraine. So it's actually pretty common. And sometimes the transmission occurs in different. You'll see it through male lines. Sometimes you see it through women. So sometimes I take care of whole generations of migraineurs, and I'll have some men, some women, and it's absolutely fascinating. Sometimes you'll see more of one pattern in men than in women. Sometimes the women have more aura, the men have less aura. Sometimes the men have more aura. Sometimes the men have only aura. And migraine's one of it's really a condition or a disorder that changes over one's lifetime, and it may change with hormonal status, it may change by decade. So it has it's much more interesting to study it than it is to have it. And although I do have migraine, but it's really important so it sounds like he's young. If he's athletic or enjoys outdoor activities, it's important to make sure that he's treated. It's also important to check things like to make sure his blood pressure is doing well, that he doesn't, that he's not smoking, all the kinds of things that grandmothers are always encouraging grandsons and sons. I'm sorry that he's lost his dad and you've lost your son. Migraine does not increase the risk of death. So migraine, though, is an aggravating, annoying, it can be a completely debilitating medical condition, though it has some increased risk of stroke. Again, higher in migraine with aura than migraine without, but it doesn't really convey an increased risk of death. So the important thing for your grandson is really to have, if it's frequent, to have his migraine evaluated if he develops it. But we'll cross our fingers that he is in the other 50%.
Yeah. Lily, thank you for your call tonight. And I think that you said, and the ladies in the back said this too, there's a gene. There's a gene that dictates whether you have migraines or not. Did you say this?
Yes, there are actually many genes.
Wow.
So there are 3 genes that have been well mapped for the rarest of the forms of migraine. These are called familial, meaning it has to be inherited. Familial hemiplegic, where there is weakness on one side of the body. So there are 3 genes for familial hemiplegic migraine, types 1, 2, and 3. The third one was actually mapped by Dr. Alfred George at Vanderbilt.
Oh, wow.
So we have a local, really a geneticist here who's mapped that. So these are genes that have specific defects in various things. The first one that was mapped is a defect in the PQ calcium channel in brain, and that defect leads to an excess amount of glutamate, the neurotransmitter that again produces an excitability at the level of the neuron. So that's how it was determined. So all the defects lead to something that increases excitability in the brain. That's why so many of the drugs we use to treat it reduce that excitability. So many of them are anti-epileptic agents.
When we come back, I want to talk about the drugs that are on the market now, what's coming, and some other treatments that are not drug related, if folks want to go down that route. All right,
Absolutely.
when we come back, more on migraines and headaches. Stay with us.
Whether a house is new or whether a house is 20 years old, we can go in and we can find debris in the lines. Mr. B's is about doing duct cleaning the best that we can do it and better than anybody else in the industry. That's what I personally stand behind and guarantee. We never make a claim that we're going to help your health. That's just something we don't do. But again, I personally believe that if I put you in a cleaner environment, it's got to have a positive impact on you. And we literally cut a hole into the main trunk line. That's the main artery, just like a tree trunk. And we attach a HEPA vacuum system to it. All right. When we do that and turn it on, it causes a negative airflow. As that machine's sucking everything backwards, we go to each line and we'll brush it, and then we air sweep it down to the trunk line. So we've taken everything back to that negative airflow. So again, whether it's upstairs or downstairs, you saw that everything is being brushed and air swept to the trunk line, not bringing it back into your breathing atmosphere. What makes my home need an air duct cleaning? You have to make that decision. It's your environment. And so if you have black lines at the edge of your carpets, or you have any sort of dust, excess dust in your home that you're dealing with, and that's a problem for you, then you definitely would want your air ducts cleaned. But most people understand too that if they'll just look down the return, take the filter out a little bit and look down the return, they'll see all the dust that they're breathing on an everyday basis. The way we do the cleaning, most residential homes will be good for 5 to 7 years. We do recommend that you have your system serviced by a licensed contractor and also use a good filter. We've been doing this for over 17 years now. We take pride in the fact that we have an A+ rating at the Better Business Bureau. Also the fact that we don't believe that anybody's going to out-clean us. And as I've said before, people can outprice me, but they're not going to out-clean me. There's only one way, and that's the right way, and that's what we do at Mr. B's Air Duct Cleaning.
Dr. Jan Brandis is here talking about headaches and migraines today on Medical Monday. We've had some great questions. Thank you so much for your calls. I want to talk about the drugs that are on the market or coming. What options do people have?
Well, there are actually only 4 FDA-approved drugs for prevention: timolol, propranolol, valproate, and topiramate. So those are the 4 that are approved for episodic migraine. Botox is the only one that's approved for chronic migraine.
Does that work?
In terms of prevention, it works for some patients. It's not overwhelmingly. It's not like it takes you to zero.
Right.
But sometimes in combination with other things, it really can help severity.
What about, you said that there's preventative and also when you're in the middle of it, or it's just beginning.
Yes. The acute medicines were really revolutionized in 1993 with the first of the migraine-specific therapies, a drug called sumatriptan. So that drug's available as an injection, a tablet, a nasal spray, a nasal powder.
Oh, wow.
I mean, it has a lot of different formulations, and that one remains an important drug. There are 6 other triptans. All of them, again, someone should exhaust all of them before they give up on triptans. And then certainly the anti-inflammatory drugs, again, if someone doesn't have renal disease, those drugs or uncontrolled hypertension, that needs to be controlled, and that's another class of drugs that's very effective in migraine. There's one that's FDA approved by itself for migraine called Cambia. We often combine those drugs with antiemetics or drugs like ondansetron, prochlorperazine, a lot of these kinds of things. And a lot of times we use combinations. Now, I always say that if somebody can take 2 aspirin and drink a little Diet Coke and they get pain-free in 15 minutes, it doesn't come back, and that happens once a month, that's a great treatment for them, because what you want to look at is once you treat, how long until you get completely pain-free, migraine-free. Does it return, important in a 4 to 72 hour attack, and does it interrupt activities? So whatever the treatment is, it should always be evaluated against those sorts of
And I can see why it's so
parameters.
important to keep that diary. So
Absolutely.
important. We're running short on time, but I want to get to Kristen on the line. Kristen, you're probably going to be our last caller tonight. What is your question?
Hi, yes. I started suffering debilitating migraines at 18, full-blown aura. So the first time it happened, I didn't know what was going on. But anyhow, I had had issues with headaches. I'm now 42. My hormones are starting to kind of change, and so my headaches started coming back with a vengeance about a year ago. However, for the prior probably good 7 years, I managed taking 500 milligrams of magnesium daily. I went back to the doctor. She started back on prescriptions. I've always had mild salt for when I have a breakthrough. But anyhow, I started having horrible side effects off the meds, Topamax, the one antidepressant you just mentioned, and that kind of thing, propranolol. I had low blood pressure, so that caused me issues and dizziness, but what have you. She put me on 400 milligrams of the riboflavin daily. So she went to a seminar, and then it's effective for women when they're pregnant. It has ceased my headaches, and I will sometimes get like little breakthrough issues, kind of signs of or a small headache, but not full-blown, put me in bed for 2 days headaches with the whole 9 yards I get. So I was just curious, since you have so much expertise, why does riboflavin work on that high dose?
That's an interesting question. Kristen, thank you for calling in. I'll put you on hold, so listen to your TV. Have you heard of that?
Absolutely. Riboflavin, 400 milligrams, so you're on exactly the right dose. It doesn't work for everybody. In large trials, it helped about half the people. In one trial, it helped about half, and the other didn't help about half. But it can be really important. It's easy to take. It works on an electron transport chain, so it has to do with the antioxidant component, and that's why we think it works in migraine. And magnesium is another important drug. So again, 400 milligrams twice a day for some people with hormonally influenced migraine like yours. People are often worse in perimenopause when the estrogens are high, estrogen level is higher. So those are 2 great medications. If they work for you, they're usually very well tolerated. So I'm so glad you found those.
That is fantastic. What about if people just want to stay away from the drugs? What are their options? Do they have options?
Well, yes, there are a couple of things. There's a new device called the Cephally device. I wouldn't honestly recommend it. It's like a TENS unit, and it can blast you. You blast it for about 20 minutes every morning. But if someone's just completely worn out with medications, it's FDA approved, and they may try it. It was studied in very small clinical trials.
You don't like it because you don't think it's very effective? You haven't seen that?
I don't think it's effective, and it's painful. But you know what?
So are migraines.
So are migraines. And if someone's just really, some people are very intolerant of medications, just like the person we just heard. Sometimes it's really hard. And a lot of the drugs can reduce blood pressure. A lot of them make people not feel, they just don't feel quite themselves. Some people are very fortunate. They can really tolerate the medications. But if you can't, then I think it's reasonable to do that. Occipital blocks are sometimes used in some patterns of migraine. Sometimes people will use, again, Botox is a therapy that, again, can be given at intervals. But if you really want no drugs, the Cephally device or Cephally device is the only one of the FDA approved approved patterns for that. There's another one that is a posterior transcranial magnetic stimulator, and the challenge with that one is you have to put this device on and turn it on at the start of your attack. That one's a little bit more cumbersome, but again,
if it works,
it works. So I think with migraine, if it's safe and it works, that's reasonable. And it's now that it's so easy to look things up and see what's really FDA approved or not. Those things can be really important. But it's always important. Plenty of hydration, limit caffeine, exercise, good sleep.
All the things we hear for everything.
Small, frequent meals. That's exactly right. All the things we hear for everything. And then the new CGRP monoclonal antibodies are going to, I think, for many people, offer great promise. Their side effect profiles are very good. and they don't produce most of the side effects that the currently available drugs can. They're not
That's
going
exciting.
to be perfect, but they may offer some real benefit.
Something different. You said probably next year.
Probably next year.
Right. On that note, we're going to take a quick break. When we come back, if you want to see Dr. Brandis, we're going to tell you how to get a hold of her. Stay with us.
This is a Storm 5 HD weather update. Sign up for Weather Call at newschannel5.com.
Rain is on its way out of the mid-state, and comfortable weather is actually on the way in. There's a little irony here. Technically, today, Monday, is the last full day of spring. Summer officially starts late Tuesday night, just before midnight. And kind of ironically, the humidity will actually be fairly low, under control for this time of year, and we're looking at seasonable temperatures. So what a departure from the heat and humidity we had last week. Speaking of temperatures, this is what it looks like across the southeast and, of course, current conditions right here in Nashville. Overnight tonight, we are going to drop down to around 63 degrees for that overnight low. Patchy fog possible under mostly clear skies and light winds. That fog mainly due to all of the moisture that's still on the ground from Sunday's rain. Tuesday will be really nice, sunshine, blue skies, 87 degrees for your top temperature, a bit of a gentle breeze. Will warm a touch into Wednesday before rain and cooler temperatures slide in for the weekend.
Wife swap murder investigation, next Inside Edition. They appeared on the TV show Wife Swap. She warned the family a disaster was waiting to happen.
Did you think to yourself, something bad is going to happen?
Now it has.
I think he snapped.
Then, is he really the world's most interesting man?
Stay thirsty, my friends.
Secrets from his love life. Next Inside Edition.
Tomorrow at 4:30 on News Channel 5.
Heaviest rain.
When storms threaten, more people turn to the Storm 5 weather team.
Active rescue situation there.
No matter where news breaks, News Channel 5 is where you connect. And when News Channel 5 investigates, people take notice. News Channel 5 remains the most watched station every single newscast. Thank you for once again making News Channel 5 the #1 source for news. We are honored to be your news and information leader.
Thank you for being with us tonight on Medical Monday, talking about headaches and migraines, something that we've all dealt with, at least headache-wise, at some point in our life. What's your word of warning to people who are dealing with a migraine and maybe not have seen a neurologist yet?
Well, I think perhaps keep a diary, mark what your triggers are, how intense the headache was, what you took, were there any hormonal influences, did you have spotting, did you have a full period? And then again, make some notation about, did you not sleep, did you have alcohol, things that are commonly known for triggering. That way you're ahead of the game.
If you want to see Dr. Brandis, here's how to do it. We have the information on the screen. Let me give you the number, 615-986-6033. Dr. Brandis, thank you. It's been a pleasure.
Thank you, Carrie, so much for having me.
Have a great night, everybody.